Hello, hello, everybody. Welcome to HIMSS22 in the NextGen booth. I'm Dr. Bob Murray, the Chief Medical Officer from NextGen, also a family physician. And I have with me Isaiah Nathaniel from Delaware Valley Community Health Center. Isaiah, you want to say hi to everybody?
So good to be back at HIMSS22. I was here last year, and it wasn't as many people. Isaiah Nathaniel, Vice President and Chief Officer for Delaware Valley Community Health.
Awesome, thank you. And we'd love to hear some questions or any way we want to take the conversation the audience wants to go. So at NextGen, we love community health centers. I love community health centers. We have a lot of community health centers that use our products, but why don't you tell us a little bit about Delaware Valley Community Health Center?
I'd love to. So Delaware Valley Community Health is a 52-year-old FQHC, and for those that don't know what that is a federally qualified health center. All that means is we receive 330B HRSA funds for us to serve the underserved market. And in that market, for Delaware Valley Community Health, that turns into UDS numbers, which we use NextGen for. Well, I know we'll get into that. So according to UDS standards, we see before the pandemic about 50,000 patient lives, which turns into about 158,000 visits per year. And that's in the traditional outpatient ambulatory space. So that's traditional primary care, adult medicine, internal medicine, optometry, behavioral health, MAT, behavioral health, dental, and women's health services. So that turns into 9 locations for us. We have about 350, 360 employees, and we have 79 providers that utilize NextGen in most of its services.
Perfect. Where are you located?
We're located in Philadelphia, Pennsylvania.
Terrific. All right, so Isaiah and I can talk about many, many things, but this afternoon we're actually going to at least start out by talking about population health. So Isaiah uses the NextGen EMR, and his health center does, but they also use our population health tool to do all kinds of things that solving problems that many people have. So Isaiah, what's the coolest thing that you've done with Pop Health so far?
The coolest thing about the NextGen Population Health, formerly Eagle Dream, let's give a shout out to Dr. Betty, formerly just now retired. One of the things I love about that tool is the geospatial information, and I know you and I talk about this, but in layman's terms, what we can do is take our population and know where spots are, know where the hot areas are, and to deal with that with the social determinants of health. And one of the things I am so proud is that NextGen owns the intellectual property rights of that prepared tool. So putting that into a population health management tool where we've had population health for decades now, and it's just now understanding that data. So when you throw that on top of a global pandemic, knowing where your patients are, knowing how to, as an executive team, understand where that pockets are so that we can be most equitable to the care of the patients that we need to, that's what's so important and significant about the population health tool.
Well, that's great. So just to kind of recap that, you're collecting all kinds of information on your patients, including social determinants of health, and then with the Pop Health tool, you're able to basically map those. Do you do it by patient zip code?
It's a bunch of different.
Yeah, a bunch of different mappings, he's saying, and then based on that, they can plan services that the community health center needs to meet needs that are in a various area. So that's terrific. So tell us a little bit more, since you alluded to it, about the Prepare tool. What is that?
So the Prepare tool started from the National Association of Community Health Centers, and it was just a collective of how do we understand our patients better, the social determinants of health, and they put it into a standard format. And so there was a version 1 that came out, and a lot of people went into that collaborative to capture that data, but it wasn't really in the EHR. So NextGen purchased the intellectual property rights and actually turned it into a template that is now a standardized format of collecting all of that, social determinants of health, collecting food insecurity, collecting housing insecurity, education problems, and then what you can do is you can tie that into the actual care coordination model, which means that you can say, all right, here's a food insecurity for this person, let's make sure we get them the proper resources so that they can have nutritional value to where they are. And in an underserved market, that is where health equity is most impactful. So that's what we use to prepare for, that's what it is, and that's how we benefit from it.
Yeah, I love that. I want to get back to health equity in a second because we were just talking with the ONC about that last week. But so to add some color to the Prepare tool, so as Isaiah said, it was initially developed by the National Association of Community Health Centers, the NAC as it's usually go, the NACHC. And they had selected it as their measuring tool for social determinants of health, because back when this was getting started, everybody knew that social determinants formed the major part of people's health outcomes, but there wasn't really standardized tools to do that. So the NAC developed Prepare, and we actually worked with them on that, and then we do incorporate that within the EHR. And folks can fill out the Prepare, as you say, as a form, as a template within the EHR. They can also send that to the patient to fill out if the patient has the capabilities of doing that. It exists as a paper form that you can use a digital pen to bring into the system, and a couple of other ways. And all of that, of course, falls in as structured data, which Isaiah and his team were then able to use. But if we get back to health equity, so specifically, one of the problems we were raising at the national level with the ONC was lots of folks are collecting social determinants of health, SDOH data now, but there's not necessarily good connections with some of the social services agencies that are going to be able to really act on that data and reduce that disparity. So where are you with that, and what can you tell others about how to help tackle that problem?
Yeah, that's a very, very good question, and it's layered in so many different approaches. I'll just talk about what we attempt to do at Delaware Valley Community Health. So we are a part of our HIE. We're a part of our Direct Trust. We are a part of NextGen Share. We are a part of Care Quality. We're a part of SureScripts. And my platform as VP and CIO is that I don't want that data just sitting in our four walls. It has to get out. That's how you solve a pandemic, is you share the information, de-identified and secure, of course, but you share that information out so that all the other institutions can grab that data and actually make actionable healthcare, quality, equitable decisions based upon that data. In traditional primary care, that's our role. Our role is to be a partner in the continuity of care. That's why you have the CCDA and the CCDR, and that's why we share that information appropriately so that when you're looking to solve a global pandemic, that data that starts at the primary care, I always talk that Mamba mentality, and we get into this all the time, that triangle offense of the predication of the basketball, and our triangle offense, primary care starts that. And then we pass it to the referring specialist, then we pass it to the hospital, and then it comes back to us. Why not do the same thing with data? So that's what we look to do at Delaware Valley Community Health.
Well, that's terrific, and I'm sure that it is a long road, but it's probably working well. But many of the social services agencies, how do they actually use that data? Because a lot of them, they're not using an EHR, they're probably not using NextGen. So how do they actually get the data that you're willing to share with them?
That's standardization. I'll just start it at there. That's standardization. Now, I can't speak to what the other institutions are using or how they are doing that, but my charge is to make sure in a standardized format it exists for you to pick it up. It exists so that you can capture it. But also, one of the things from a social services perspective, we have taken advantage for some that are doing it well. For instance, Aunt Bertha. We tie right into Aunt Bertha through that Prepare template. So when you calculate that score, it can determine where Aunt Bertha needs to send you. And so we like that as one of the methods and tools from a social services perspective that we do that.
And then are you able to capture any outcomes, or what are some maybe patient stories from just that handoff between your community health center and either the social services that you provide or some of the ones that Aunt Bertha might be coordinating?
So, our care coordination team is something that we utilize a lot. And some of the good stories that we heard through the pandemic is, if not for us sharing our data, there was a pregnant woman who was COVID positive. And if not for us sharing our data at the bedside, it wouldn't have induced that baby to be able to save that baby's life during the pandemic. And so that's just one of the great stories that we are so happy. And, when we talk about the technology, when we talk about structured data, we don't talk about the impact of it. We don't talk about these types of stories that if our data was not shareable, we could not have caught that positive result, because when you take a test back in those days, it took a day or two for that to get back into the EHR. But what happens is, what we do with NextGen is that we automatically send that to our HIE. We automatically send that once that medication comes back in, or that result, directly to where it needs to go. So when a doctor or a provider is at the bedside, OBGYN specialist is at the bedside, they can pull that data in and reconcile and say, oh, wait, we need to induce this right now because this is a positive result. The patient didn't know, but now we can save a patient's life. And that's what gets me up in the morning, Dr. Bob. I'm going to get off my soapbox. I'm going to begrudgingly hand this back to you.
It's not a soapbox at all. I mean, your passion at caring for your patients is wonderful. That's what we love to talk. So, but you're mentioning HIEs a number of times in the middle of all this, and we're right there with you. NextGen has software for HIEs, but we also believe in the role that the HIEs are beginning to play, not just as exchangers between health systems, but also between health systems, providers, CHCs, social services agencies, et cetera. Because those HIEs, they are kind of, as Moshe Shabli, our interoperability guru, says, he says that they're the only ones that are incentivized to actually make those connections, right? Because the value of the HIE increases with the number of things that connect to it. It's a network effect. And so they have a great role to play in giving that data where it needs to go, and therefore, hopefully, in reducing health disparities. All right, maybe we'll turn back to Pop Health, because you mentioned your favorite thing that Delaware Valley CHC is doing with it, but what's maybe your next favorite thing?
My next favorite thing is the behavioral health component. And I say that because during the pandemic, we saw that this explosion of mental health. We started to talk about it more. And one of the things that we, at Delaware Valley Community Health, we added that as a service line before the pandemic. So understanding that behavioral health is part of the whole person, and now we get to take advantage and integrate that into the medical continuity of care. I mean, you just walk in our door and you can leave a whole person if you choose to. You can get behavioral health services, you can get dental services, you can get, the whole family can take advantage of our services. And so adding behavioral health, adding that component to our EHR, so that if you need a referral to a behavioral health specialist, you just click a button and you can have that visit right then and there.
Now, is some of the data from the behavioral health, which of course is just part of your EHR, or from the dental care that you're delivering, is some of that part of population health, and does it come into some of the care management or other types of things that you do with that Pop Health product?
Absolutely. That's the simple answer, is absolutely. By having all of these products so intertwined with each other, they're just as simple as a click or a HL7 integration that allows you to have all this data that can funnel into population health. And I think it's interesting, and I'm so happy that we're starting to talk about this as an industry. What is social determinants of health? It's not an anomaly anymore. It's not just something that's in the primary care. You're hearing hospitals talking about it. You're hearing everyone starting to understand that this is the data we need to be actionable, to do what we are charged to do, and I'm just happy about it.
Oh, that's great. So I'm curious, with the Pop Health software, what kinds of users are looking at that data, and what are some of the things that they're doing with it by role? Because as we talk to folks, they're not always sure, well, who looks at this? Is it the medical director? Probably the care manager, but who else besides do you have looking at it?
It's the entire clinical team. It's the chief medical officer, it's the chief quality officer, it's the care coordination. It's literally everyone down to the point of care is looking at this data, because you could do huddle sheets out of the population health management tool. So when you're starting your day as a medical director, you're getting a list of the patients. You can say, okay, provider A, provider B, let's definitely go forward and see where the care gets is. But the other nice thing, and I was waiting for you to throw this alley-oop, is the API injection at the patient level. I can't tell you how impactful that is, because for provider one to look at a chart for patient A and say, here are the care gaps for today, if you click on that, you can see what you need to do to be able to be successful at that visit. So you're not waiting for a second visit or a third visit to get that information back in. That's at the first visit. So what does that do? That reduces waste. And that's what we're all trying to do. It reduces the waste on the revenue cycle. It reduces the waste on the actual clinical opportunity that you're having. So now you're able to, with health equity, reduce what could be a 3-month gap between seeing what was going on to now at that primary care visit.
Yeah, it's great. I mean, what Isaiah is referring to, of course, is that we have a heads-up indicator in the EHR that's summarizing what we would say are the most actionable insights from the Pop Health, care gaps and risk scores. I think it's also important because some Pop Health tools or some tools that maybe some of the payers would provide you, well, that's based on claims data, but there's some issues with that are obvious. What are they?
MCOs, love them to death. So, some of my frustration with that is, the capitation model. Some of my frustration with that is that the true claim? And so being able to ingest that information into our population health tool is helpful for us. But as an executive team, one of our strategic goals is to lower our RAF score. And we use the population health tool because it risk adjusts based on the ACG score from Johns Hopkins, all of our patients. So you go down to the patient level, but you can also come up to the higher executive level so you can understand. So when you make an executive decision, you're saying, okay, this is affecting our population as a whole, as well as the population that's at the chart level.
And I think that's another common use of Pop Health is you want to distribute your precious care management services or social worker services or what have you to the populations that you feel are most in need or at highest risk. And it sounds like you're doing that as well. Tell me a little bit more about the huddle. I think that's fairly common these days, but it's probably not common that people use their Pop Health tool in the huddle all that often. So how are you doing that?
So what we do for the huddle is just basically that's how you plan your day, how you plan your weeks. And you say, this is all the patients on a provider's schedule, where are the care gaps? Where should we be focusing in this visit with this actual patient? So just in very layman's terms, we're using it to help our health centers plan their days, plan their access for the patients. And what that does is it reduces the barriers to access. It reduces the barriers to clinical opportunities, and it reduces the waste from that patient activity on day one versus the patient activity when they come back in a recall opportunity.
Yeah, I mean, as a primary care provider myself, so I love the daily huddle, and I think it needs to be realized that it takes a team, even on the day of the visit, just to take care of that patient. It takes a team, right? That I'll be responsible for some of those gaps in care, but it's very helpful if the rest of the care team is responsible for others. It's just the most efficient way to provide it, and then you don't have to think of 100 things as you're seeing the patient. You have to worry about just the ones that you're thinking of is there. So do your nurses use the Pop Health tool beyond the huddle?
Yes, our nurses use it for a bunch of different opportunities related to RPM services now. We're using it for a lot of vaccine distribution, a lot of that whole model and how we deliver care. Our nurses and our clinical teams are using it well.
Terrific. If there are questions from the audience, we're happy to take them. So what do you think is next for Delaware Valley and Pop Health and health equity and that realm of topics?
I think healthcare is in a great state. And I'll say that because this is the innovation, this is the disruption that we've needed for quite some time. So I am happy. I get up joyfully every day because we get to continue to make a difference by using our EHRs. And, it's at the point where providers will say, oh, I don't like this or I don't like that. But if you take the time to understand not only what the provider wants, but what your EHR can do, you can bridge that gap a lot closer. And what I love about NextGen is the customability of it. You can customize a template. You can customize your workflows to be equitable to that different provider. So while you want to make an overall decision, you also can make those point of care decisions for your provider for that quadruple aim, which we're waiting to be official, that quadruple aim and provider burnout, to reduce itself. So for me, what I'm looking at is how do I optimize NextGen so that I don't have burnt out providers, because we're all experiencing burnout. How do I optimize NextGen so my staff doesn't have to do so many updates to keep them sane? So these are the kind of things that I'm looking forward to, and just a basic stabilization of healthcare overall.
That's terrific. I think from my standpoint as a a primary care doctor, so yeah, we all want the EHR to have fewer clicks, et cetera, but I think what we really want is to be part of a team that we know is really going to take care of that patient, that's really going to be able to provide not just for their needs medically in the exam room, but their behavioral health, their dental, their social needs, et cetera. And it sounds like you're able to provide that environment for your physicians and the other members of the care team. So, all right. So, any final thoughts from Isaiah? What else do we need to know?
Well, I just want to comment on what you just said there, because one of the things our CEO said, and he's a doc himself, is that he likes the interconnectivity of the team. And so when you have that coming from the top, that goes throughout the entire organization. So not just what is IS doing in the EHR, what is clinical doing in the EHR, what is operations doing, what is quality doing, and how do we innovate? So it's not always this IS-led function, it's the organization leading with a single goal of providing great quality care. And so when you have a CEO doing that, then that just funnels to the rest of the organization. So I mean, for me, I'm happy to be in a position where we can create change. And so my platform is to reduce those access barriers by the way of technology. And if I know my technology, if I have technology at my fingertips that we can manipulate to make sure that when a patient wants a visit, they can get it, I'm a happy CIO.
Love it, love it, love it. All right, Isaiah, thank you so much once again, and we're actually chatting again tomorrow, but once again, Isaiah and Nathaniel from Delaware Valley Community Health Center. I'm Bob Murray from NextGen Healthcare, and that will end this Fireside chat. Thanks, Isaiah.